Welcome to Disability Clinic, where healthcare takes its medicine. I'm Dr. Stephanie Van, a Vietnamese woman with long dark hair, wearing a dark blue blazer and blouse, sitting in front of a colorful bookshelf. Joining me today is Ro Bowman, nurse navigator at Johns Hopkins Medicine and the co-chair of the Employees with Disabilities and Allies ERG. Welcome to the show, Ro. Thank you so much for coming on.
Thank you, Stephanie, for having me. As you said, my name is Ro Bowman. My pronouns are she or just my name, Ro. I am a white woman with red hair that kind of does its own thing. I'm wearing a blue sweater. I'm in front of a teal background. Got a lot of artwork on the wall behind me. I have been a nurse since 2008. Prior to that, I served in the Marine Corps for 4 years. I got injured initially when I was in the Marines from 2000 to 2004. And, let a lot of that Marine Corps bravado of, it's just a flesh wound. You walk it off and be tough, and ignored all of the pain in my body and everything it was trying to tell me until I woke up and couldn't move my left leg. So that was when I was like, wait, you mean I'm supposed to pay attention to my body?
Maybe it was trying to tell me something.
Or the pain had a function. It wasn't just there for me to drink water, take Motrin, and change my socks. That's what I was told pain was for. It's been challenging getting acquainted with having a disability, one that is worse than it would have been had I otherwise actually gone to a doctor.
And of course, hindsight is 2020, and you still have to celebrate the fact that you are taking care of your body, or you're at least tuning into it more. That's what it deserves.
I think in medical culture, it can be really easy for us to ignore, well, is it broken enough? Are you sick enough? Where it's like, well, you don't want to come in when it's, just strep throat. Wait till you're almost completely unable to pass air. I don't know if you see that on provider side in medical culture as well, sort of this.
Oh, definitely. There's definitely a line like you're talking about where it's acceptable to be not 100% well, but still be expected to show up to work, give your 100%, show up for patients. And I mean, what we're really hammering on about is ableism, right? It's that expectation of you better be able to deliver and function and do what you need to do. You have to appear like you tolerate, oh yeah, of course, if you need a doctor's appointment, sure, go ahead. But there's this hidden agenda of it can be looked down upon or punished. And nobody wants that reputation as much as it should be comfortable and safe for everybody.
Exactly. And it's also needing this external validation of, I worked with a resident who told me once about working a shift with a chest tube in.
Oh my gosh.
I didn't see it with my own eyes.
Did they get the chest tube at the hospital they're working at and then just decided, I might as well work while I'm here?
Well, there was no one else here to cover my shift. So, I'll just intermittent suction.
That's definitely over the line.
Right. But it's that okay, I can see there's something going on. You're allowed to not be at 100% because I see this external thing. I see this chest tube.
Right.
I give you a little grace. If that's not seen, they're just well, why aren't you running around at 100%?
Yeah. It's so much easier to doubt someone's need when it's not apparent or visible. It's so interesting though, because it's okay that there is a line, right? It's we're not trying to say that you can just take a day off whenever and get out of work. And I feel like that's a big misconception that happens all the time, when really, I think that's the minority of cases, but there's just such a bias that that's what people think happens.
And then what you end up with is people pushing themselves way too hard,
And then hurting themselves more, and their performance suffers, and then other people might suffer. It's not a good combination.
It's validating to know that on the provider side, not just the nurse side, you see it as well. We really do want to be able to be that person that's well, yeah, if you need a doctor's appointment, if you need the time, go take it. But I myself, however, am, completely invincible, and, I don't need to go to the doctor, right?
It's so funny you're touching on that. That really resonates with me, because sometimes my patients will be like, you responded to this message on the weekend. Are you taking time off for yourself? Or you don't need to come in at 7 a.m. for me, And so they're reminding me to take care of myself when it's, usually it's supposed to be the other way around.
So good patients.
Yeah, I've got some good people. I'm at the end of the day, that's what it is. There's been this historical divide. Oh, we're the providers, we're the nurses, the caregivers, and then there's the patients, and it's an us and them. Really, the perspective is that we could all be patients at any time. And some of us just happen to also take care of patients. I feel like that's a healthier way to look at the healthcare profession.
It is a healthier way to remember that you too can be upon that gurney I know I'm a much better nurse for having been through what I went through. There's just a level of understanding and empathy of, I understand what it's like to not be able to put my own socks on now. You know, I went from one day being active ER nurse, you know, taking small buildings in a single bound to needing 2 people and a walker to get from the bed to the commode. That was an abrupt paradigm shift.
It's so funny how many people who are brave enough to put themselves out there and say, hey, this is my story, this happened to me, even when that can be a very glaring like reality of like, hey, healthcare needs to do better. I still see people get dismissed or kind of ignore it or just have this attitude like, oh, that's not going to happen to me. I don't know how else to kind of get through to people that this is important. It's like the only thing you can do is just put your story out there, share it and highlight it as much as you can, and then hope that people catch on before they suddenly have a personal experience themselves.
The other side of that too is, okay, we need to get home that people need to listen to themselves, listen to their body, listen to themselves, go in for care, but also getting through to providers that avoiding that diagnostic overshadowing. Okay, your back hurts, but really what you need to do is lose 30 pounds. And it's like, well, actually, it was a much bigger problem with my spine than a little extra weight. We almost sometimes preemptively dismiss ourselves because we're like, well, I'm just going to go to the doctor. They're just going to tell me I'm overweight. So why even bother, right?
Yeah, it's a vicious cycle of not expecting much from a healthcare provider. That doubt is founded in past experience. It's like, okay, if you've been dismissed by doctors before and your symptoms have been ignored, why would you go back there just to be told the same thing? Do you want to give me a few more anecdotes of, I don't know, you mentioned diagnostic overshadowing, right? Like all hail Dr. Lisa Iazzoni and her amazing work on highlighting these issues. So, you know, diagnostic overshadowing for our audience is that phenomenon where someone presenting with new or worsening symptoms, they already have an existing disability. Those symptoms get lumped into that existing condition and workup or treatment might be delayed, which can increase morbidity.
I learned about diagnostic overshadowing first with a more colloquial name, and it was when I was working at the Center for Transgender Health. It was known as transgender broken arm syndrome. It came about when a person had been playing soccer, went for a dive, got kicked right in the arm, went to the ER, got seen for the broken arm, had an x-ray done, sitting in the room, provider walks in, they're talking about the broken arm, provider logs into the chart and sees that this patient is transgender. And it's like, well, maybe your bones broke because you're on hormones and that's why this happened. And really you should stop being on hormones now. Anyone who got kicked in the arm would have their arm broken. But it's that diagnostic overshadowing of, well, your arm was broken because you were transgender.
That's right. So horrible.
And then it's like this phenomenon got filtered into this really amazing term of just this diagnostic overshadowing. And it's like choosing which lens we're going to look through.
Absolutely. It's a great term to put a word to something that I think a lot of providers experience and see, but they don't quite know how to describe it.
I feel as though I have to sell myself as a reasonable person who has back pain. My condition has to do with my spine. I like to say that half my spine is a hardware store and the replacement parts are not as good as the originals. I started off in the ER and that's where I was for a very, very long time. And just the culture I observed, I felt like there was often sort of this side eye when someone would come in with back pain. You know, you'd hear providers go, yeah, my back hurts too, like, and I'm working. You know, I internalized that so much that when my back hurt, I didn't go to the doctor because I was just going to get told, well, of course your back hurts. You're a nurse, which they do tell you in nursing school. They tell you you will have back pain. And, you know, in fact,
at least you're prepared.
Right. As I'm laying on the stretcher the first time and couldn't move my left leg, and the president who I adore walks in, he just looks at me. He's like, do you have back pain, Ro? Of course I have back pain. I'm a nurse. Why would I not have back pain? No, really, you should see the MRI. Oh, that's bad. You know, I would hope people wouldn't be dismissive of someone's pain just because they can't see it. It's like we talked about with the chest tube. You know, if I could walk around and you could see 6 swords going through my spine, you'd go, ooh, that probably doesn't tickle. But you can't see it. I'm not bleeding out. I'm not hemorrhaging. There's nothing protruding.
Not a cast, right.
Right, yes.
You're reminding me, like, there's a pearl of wisdom in medical school you learn pretty early that even when someone's imaging shows one thing, their pain or their symptoms could be wholly different. You could still come in with severe limiting pain and your MRI might not look, you know, super impressive or scary. Doesn't mean that pain's not quote unquote real, but that makes it even harder for healthcare providers to kind of validate those symptoms and still treat it appropriately as opposed to dismissing it, which is not helpful.
I'm not trying to give any grief to the ER. It's a very dynamic environment. The person with the back pain is not bleeding out in front of you. So it's even easier to go, oh, that's probably not such a big deal. I always felt like too, there can be the sense that, oh, well, they're just, drug seeking, right? That horrible, horrible term. I know that you called it pain relief seeking behavior. And I was like, that is such a healthier way of looking at it.
I like to think so, yes. I'm hoping that catches on.
I'm getting a t-shirt.
Oh my God, I love it. I want one.
There's so many layers mentally of getting through before you even get into the door to the doctor to go, I have a problem, right? It's like, oh, I'm dismissing myself. I'm supposed to be in pain. Oh, well, they're just going to say it's in my head. Oh, and they're going to tell me to lose 30 pounds. So it's like all of these layers compounding each other, making it so hard. I don't have the statistics in front of me, but something that I saw too in the ER was the gender divide from when pain was treated. I did very lovingly called a few providers on this a few times of like, okay, a guy is coming in here because his left testicles exploded. You're like writing morphine at the door. But if, a woman is coming in with severe abdominal pain, it's like, have some Motrin and we'll wait and see. I got yelled at one time by a provider. There was a young woman who came into the ER, severe abdominal pain. I have her in triage. She's like, this is exactly what it felt like when my left ovary torsed, and I waited a long time and it was dead and they had to take it out. And it's exactly how this feels on the right side. Normal ER sort of triages, that would have been like a 3, a right in the middle. You're going to need some workup, you're going to need some labs, you're going to need some meds, but you probably don't need to go straight to the OR. But I heard her story, I did her exam, and I categorized her as a 2. A 1 is like you're actively dying. I categorized her as a 2, and I had a male doctor yell at me about it and call me on it. And I was like, no, if this was the man in here and we were talking about testicular torsion, he would automatically be a 2. I'm like, but this is a 23-year-old person whose future fertility is completely at risk. She's down to 1 ovary. Obviously, there's a history of him torsing. Like, she knows what she's talking about. Like, no, I'm not sitting her back in the waiting room.
Not only do people with invisible, debilitating conditions get dismissed, but there are other marginalized subsets within that. Women, for sure, notoriously have undertreated pain. People with mental health disorders. I mean, I guess that falls into invisible illness.
Right, absolutely it does.
Racial minorities. Like, there are very clear inequities across healthcare. It's frustrating to hear that it was, if a colleague didn't agree with that ranking, yelling at you about it, obviously is not the most productive or helpful strategy. And it's like, I can understand maybe he had some frustration in terms of, there are other priorities, or
it's a busy night. And
sure, yeah, healthcare providers are already pushed to their limits in terms of shift work and being underpaid, undervalued. So maybe he was bringing some stuff to the table that you don't even know about.
No, absolutely. And I don't want to discredit that at all. Everyone can have a lot going on personally that, and their lens of experience is very different. I lost a colleague to suicide, and it breaks my heart that I couldn't see through his head, that I didn't know what was going on. And it's very real in medicine. Absolutely. We always want to give each other the benefit of the doubt.
Yeah, I'm so sorry that happened. That's tragic, and it happens way too often. It seems unsurmountable sometimes, especially when we're all still so uncomfortable talking about it because it can be so painful and we can feel so helpless. But I really appreciate you just highlighting that.
I'm glad you helped put it in the frame. Everyone is going through their own experience, and none of us can know what was going through the provider's head when he was like, why did you make this person a 2 and put them in a room?
Well, that leads me nicely to the fact that we have disability ERGs, right? These types of groups are being created and exist now. The fact that we have spaces where fellow colleagues, healthcare employees, students can gather and even just have conversations and dialogues about these things. We're not trying to problem solve or come up with this big sweeping solution, but just creating that community. I feel like that's a big component of how we can heal and how we can support each other. Absolutely. So thank you for your work with all of that.
Thank you. I knew I needed it, and I knew I wasn't alone. So it's like, it's the whole, if you build it, they will come, right? I can't be the only disabled employee out here going, I need my community.
If you want to hear more conversations like this, hit that like button and subscribe to Disability Clinic for more accessible and entertaining education. Thank you so much for watching, listening, and learning.